So our first speaker, I'm so proud to introduce, is Dr. Igho Ofotokun. He is a professor of medicine at Emory in the Division of Behavioral Science and Health Education and specializes in infectious diseases. He's a clinician scientist who's centered on providing care for persons with HIV, particularly women who are affected by HIV, and getting them into clinical trials. We've learned from the cholesterol guidelines how important HIV is to women, and we're so proud that he is dedicated to this research. And in fact, he has received the Nanette Casswinger Distinguished Service Faculty Award in 2017 for his contributions. He's the co-founder of the Emory Osteoimmunology Clinical and Translational Research Group. He has one of 2 AIDS clinical trials groups ongoing, and he serves as a member of the FDA Antimicrobial Advisory Board. We couldn't find a leader more dedicated to women with HIV, and I'm so proud to have him today. Dr. Ofotokun.
Thank you very much for the warmth introduction. And thank you most importantly for inviting me to share our thoughts on the subject of cardiovascular disease in HIV-infected patients with your audience. It's really a honor. Infectious diseases permeate every aspect of our lives. And the subject of the intersection of infectious diseases with cardiovascular disease could not be more relevant in this era of COVID, where we know viral infection, most infection, even at the end when people survive those infections, eventually end up leave damages that affect various organs, including cardiovascular disease. And we see that a lot with HIV infection. So these are my disclosure, mostly pro bono work with various groups, both within the country and outside of the country. So these are the objectives of my discussion with you this morning. I plan to provide an overview of the burden of cardiovascular disease in our patient population, the HIV/AIDS population that is currently aging. And I thought that it would be important for us to discuss, for me to share with you some of the work that we're doing here at Emory to really improve our understanding on the pathogenesis of HIV-associated cardiovascular disease and other comorbidities. So many of you, everybody I think would be familiar with this slide. We know that HIV disease management has been a phenomenal success. When the epidemic first broke in the 80s, from this study from Denmark, almost everybody that was diagnosed with AIDS died within 6 months of diagnosis. So AIDS diagnosis was a death sentence. Then in the mid-90s, the highly active antiretroviral therapy was introduced, and we saw a significant change in morbidity and mortality. Life expectancy increased significantly. HAART improved, and we saw even a more significant improvement in life expectancy of people living with AIDS. Today, people living with HIV/AIDS have a life expectancy that is approaching that of the normal population. This is true in Denmark. It's also true in many Western countries, but more importantly, the impact of HIV treatment is being felt the most in sub-Saharan Africa, where the burden of HIV is most severe. So this was a study from KwaZulu-Natal in South Africa, close to Durban, where we looked at life expectancy before, at the peak of the AIDS epidemic in the early 2000s. You can see a significant drop in life expectancy. Then antiretroviral therapy was introduced in early 2000. And what you saw is a huge improvement in life expectancy that continues to improve until this day. We see this pattern in South Africa, We see it in almost every African countries where antiretroviral therapy has been rolled out. The other thing that we have seen with treatment of HIV is a significant evolution in antiretroviral therapy. When I was a medical student and a resident, it was a cocktail of pills. You chalk down about 10, 12, 15 pills in the morning. You get another load of 20 pills in the afternoon. And in the evening, you maybe get about 15 or 20. And then before you go to bed, you get your last cocktails. It was difficult. I spent my residency training managing the side effects of antiretroviral therapy. Today, treatment has significantly improved. We have one pill once a day. Almost most people that are treated with HIV today have a regimen that is mostly one pill once a day. And in the very near future, I'm talking of not years, but months, 24 months, 36 months from now, we're going to have long-acting formulations. Formulations that can be taken once a month, once every quarter, maybe twice a year to keep people virologically suppressed. So there's been a significant improvement and therefore also a shift in the priority of HIV disease management and clinical research. These thoughts of ending the epidemic, of curing HIV, is no longer fantasies. They are things that we know, they are things that are now achievable with the advancements that we have made in the treatment of HIV infection. So, but with this advancement come new challenges, that of people living longer and having age-related comorbidities. So this is the data from the CDC HIV outpatient cohort study. Over 80% of this cohort are men, looking at the burden of comorbidity in the HIV population. You can see as early as the 4th decade of life, you see major accumulation of HIV-associated comorbidities. So this is a study from the Women Interagency HIV cohort study, a study that was done by one of my fellow, Lauren Collins, looking at the burden of comorbidities in women living with HIV. So this is the prevalence of comorbidity. And you can see that at every age stratum that we look at, we see a higher burden of comorbidity in HIV-infected women in red compared to HIV-negative women. What is even more surprising in this exercise that Dr. Collins did was not just the prevalence of comorbidity, including cardiovascular disease, but the incidence, the accumulation of new comorbidities was significantly higher in women. And this began as early as the 22nd decade of life. So when you look at HIV-infected women, and you look at every stratum, age stratum that we looked at, you see a higher burden of accumulation of comorbidities in this population. So this is a modeling exercise that was done by a group of scientists, clinicians, and community activists that was published a couple of years ago, looking at the trajectory of heart disease, myocardial infarction, and heart failure in people living with HIV. And this trajectory is self-explanatory, that as this population is aging, we see a significant increase in the burden of heart disease. And what is even more surprising is that this burden is more severe, more prevalent in low resource-limited countries where the burden of HIV is highest, countries that are least prepared to screen, diagnose, and treat these conditions. So this is taking it back home here in the US. So this is a study that was done about almost 15, 16 years ago by one of our friends in Massachusetts, Dr. Virginia Trent, looking at the events of acute myocardial infarction using the Medicare data of over 200,000 people in Massachusetts. And what you can see here is that as early as the third decade of life, you see a separation in the burden, the event of cardiovascular disease, acute myocardial infarction in the HIV population. Here is a similar study that was done in New York by David Hanna and Robert Kaplan. Again, breaking the data into men and women. You look at trends in cardiovascular death, both attributed and contributed. Cardiovascular disease, heart failure, and hypertension. You see over a period of 10 years, you see a gradual increase in the trajectory of all of these heart conditions. And what they found that was very revealing was that the slope, the increase in the trajectory was more profound among women living with HIV. And this point was brought home by this study that was recently published. This was a VA cohort, believe it or not, where you have, they looked at over 2,500 women, both living with HIV compared with HIV negative. And you can look at the probability of cardiovascular-free survival over a period of several years. So you can see that the burden, the hazard ratio is 2.8. So the difference in cardiovascular disease that you see between HIV-infected individuals and HIV-positive individuals is more pronounced among women compared to men. So the question our group has, and this is really what I want to share with you today, is what is driving this event? Why do we have more cardiovascular disease in HIV-infected individuals? Why is the burden more severe among women living with HIV? So I'm going to share some of our thoughts and some of our work in these areas. First of all, this is the data that was generated from the MWSCS combined cohort study, a cohort that I am involved in that is now in review. We know that this population, the HIV-infected population, the AIDS population, is a marginalized population. It's a population that have all of the risk factors associated, the traditional risk factor associated with cardiovascular disease, metabolic characteristics, history of smoking, and if you look at their risk score, for example, they are significantly high. So this is not the focus of my talk today. The other point I wanted to make is that many of the social determinants of health are stacked against this population. So these are populations that have very limited access to care. These are populations that have limited access to screening. These are populations that live distance away from any healthcare center. So there's somebody in our group that is looking at this. But what I want to focus on today is the biological factors. After you control for all of these risk factors, traditional risk factors, you control for the social determinant of health. We find out that HIV by itself, the impact of the virus itself, drives many of the comorbidities that we see in this population, including cardiovascular disease. And it does this by increasing inflammation. So these are some of the markers of inflammation, biomarkers of inflammation that we have looked at in our cohort, in the MWSCS combined cohort study. Almost every markers of inflammation that you look in this population is elevated. Our group has been particularly interested in TNF-alpha. So it's been a team science approach. There have been many of us here at Emory that has really been thinking of this. And I am going to share with you today some of our work in the area of the reservoir, the viral reservoir itself, the concept of disease reversal, and also the impact of gonadal reserve in driving some of the inflammation that we see in the HIV population that drives many of the comorbidities, including cardiovascular disease that we see in this population. Before I do that, I just wanted to highlight a few things that are different in cardiovascular disease in HIV-infected population compared to the general population. First, we know that many of the risk calculators underperform in people living with HIV. So this was a data that was presented about 5 years ago in one of our national meetings. So this is the predicted rate when you use the Framingham risk score, but this is the observed rate. And you can see a significant difference between the predicted rate and the observed rate. 2, and if you look at the American Heart Association CVD risk calculation, again, you see that this traditional risk calculator for cardiovascular disease grossly underperform in this population. This is also true for other end organ. For example, for bone, where we do a lot of work, the FRAX index is significant, is woeful, does not in any way predict fragility bone disease in this population. It does perform woefully compared to the cardiovascular risk calculator, suggesting that the mechanism of these diseases are different in HIV-infected individuals compared to the general population. The second point I want to make is that the pattern of disease, the presentation of diseases in HIV-infected individuals is different. So this was a work that we published, I think, last year in collaboration with some of your colleagues in the Emory Cardiovascular Cardiology Division. 3 things I just wanted to share on this slide. Most people with HIV tend to present with a single vessel disease. The second point is that when they present, they are likely to present with STEMI. Don't ask me what STEMI is, but that is what my cardiology friends tells me. And then more importantly, even though they have a single vessel disease, when you look at the severity of their CAD by the Gemini score, HIV patients tend to have more severe disease compared to HIV negative individuals. The other point I want to make is that if you look at C-reactive protein, we all know from just basic cardiology that C-reactive protein is a marker of inflammation, is a predictor of a progression of disease in the general population. This exercise that Caitlin Moran did when she was a fellow with me, she's now my colleague, she looked at C-reactive protein among women living with HIV and among the HIV negative women, and then look at it in relationship to the progression of cardiovascular disease. And what she found was that why C-reactive protein predict progression of disease either as measured by CCA plaque or by the carotid intima media thickness. It does not predict a progression in HIV-infected individuals. Again, suggesting that there's a different mechanism of disease for this population. And lastly, the distribution, the pattern of peaks of disease, of cardiovascular disease, or ischemic vascular injury in general, is different in the HIV population. You see a peak at the early stages, early decades of life, and then there's it evens off, and then you see another peak as people age with HIV infection. So let's go back to the subject of inflammation. So one study that really highlights the significance of inflammation in driving cardiovascular disease in HIV was the SMART study. The SMART study in Australia and Europe. SMART stands for Strategy for Management of Antiretroviral Therapy. What the SMART study suggested was that if you measure these markers of inflammation, high sensitive C-reactive protein, IL-6 and D-dimer, in particular IL-6, people with high IL-6 over a period of 1 year will progress to have a cardiovascular event. So when you look at people in the first quarter, the highest quartile compared to the lowest quartile. So you can take people today, take HIV-infected individuals today, look at their IL-6, and you can tell those who would have a cardiovascular disease. So the question, therefore, is that Why do some people have elevated IL-6? These are all HIV-infected individuals. They have low CD4 cell count, they have high viral load, some of them have AIDS. Some have high levels of inflammation, others do not. So what drives this? So let's go back again to what HIV does to the body. So HIV is a disease of the immune system. You all recall that the largest immune organ in the body is the GI tract, the bowel, particularly the Peyer's patches in the small intestine. So most of the damage that you see that HIV does to the body happens mostly in the GI. So what you see outside of the GI is just a tip of the iceberg. When you treat people with antiretroviral therapy, you do not restore the damage that is done to the gut. So many people with HIV have what we call the leaky gut. So the mucosa barrier is permeable and is therefore leaky. We also know that there's changes in the microbiota in HIV-infected individuals. And then lastly, because HIV is a disease of the immune system, and the bulk, the 90% of CD4, 97% of CD4 cells reside in the gut. The gut is a sanctuary site or a reservoir for HIV infection. So what does that mean? So Cecile Lahiri, who is now my colleague, was my fellow a few years ago, started to look at what happens when you start people on antiretroviral therapy and you suppress their viral load in the plasma, which is what we measure when people come to clinic. You say their CD4 cell count is high, their viral load is undetectable. So you see, so here we recruited individuals who were starting treatment. They started antiretroviral treatment. And then within a period of 2 weeks, they used one of these potent integrase inhibitor. Within a period of 2 weeks, many of them were undetectable. And they remain undetectable, suggesting that they were taking their medication. This is in the blood plasma. Then if you look at the gut, we did a rectal biopsy in these individuals, and then look at the viral load suppression in this individual. Why all of them are suppressed in the plasma? If you look at the gut, you see that only a few of them at some point achieve undetectable viral load in the gut, the sanctuary site. So what does this mean? So people are suppressed in the plasma, but if you look at the gut, you see tons and tons of viruses, in the GI tract. What does this mean? A lot of things. So what we did was that we looked at people who had viruses in their gut but are suppressed in their plasma. And then we look at that in relationship to markers of inflammation. So remember, not everybody have high levels of inflammation. Some have high levels, some do not. So when we look at this in relationship to suppression of viruses in this sanctuary site in the GI tract, we find out that if people are undetectable in the GI tract, their levels of inflammation is low. But if they have detectable viral load, they have high viral load in the GI tract, they have high levels of inflammation. And this is true when you look at IL-6, when you look at D-dimer, or you look at TNF-alpha. So what Cecile is now doing is going back to look at how does this presence of viruses that drives inflammation, systemic inflammation in the presence of viruses in the GI tract that drives systemic inflammation, how does this affect end organ damage? How does it affect cardiovascular disease and cardiovascular related outcomes? So the other concept that we have been looking at is this concept of disease reversal. So when we treat people with antiretroviral therapy, we give them antiretroviral therapy, we kill the virus, so you suppress the viral load to undetectable. And what happens is CD4 cell goes up. One concept that many of us are very familiar with is the concept of immune reconstitution inflammatory syndrome. So what that means is that if you have a pathogen like cryptococcus, mycobacteria, either TB, atypical mycobacteria, or other pathogen, even viral pathogen, as the immune system begins to go up, they will attack this pathogen, and then people will develop inflammation. So people are being treated, they're supposed to get better, but then you see these viruses or mycobacteria or bacteria, TB that is hiding, just flare up even as their HIV disease improves. So that is kind of the syndrome we see with COVID, where people have this cytokine storm because the immune system react. So in a sense, this happened in some individuals with pathogens, with that harbor pathogenic bacteria. But in a sense, everybody that is treated with HIV actually experiences immune reconstitution. CD4 cell count goes up, viral load goes down. So does this contribute in some sense to inflammation? So before we take that further, let's look at how immune reconstitution occurs. So the immune cells are produced in the bone marrow, and in children and in young adults, the lymphocyte precursor goes to the thymus, and in the thymus, they undergo maturation. They are presented to various antigens. They acquire the T cell receptor, different T cell receptor, and they mature and differentiate into CD4 cells, CD8, gamma delta T cells, and the alpha beta T cells. And then it leaves the thymus through this systemic circulation, goes to the various lymphoid organs, lymph node and other lymphoid organs in the body. So remember, the thymus involutes in young adults. As you mature from adolescence to young adult, the thymus involutes become fatty. So the process of immune reconstitution in adult is not the same as you would see in younger people. So what happens is that in HIV infection, by implication, is that if you're an older individual, your thymus is involuted. So this process of the reconstitution, it's not as complete. So you have homeostatic expansion of already existing cells. They are not able to go to they don't go to the thymus, and therefore they don't undergo the usual maturation that you will see. So the consequences is that you have contraction of the T cell pool, and also you have a decrease in the T cell receptor repertoire diversity. And then there's also generation of what you know as a virtual memory cells. So that is memory cells that have not been exposed to any antigen. Remember that T cells, cells that are proliferating, are also activated. And the other thing that I mentioned earlier on was that the gut is leaky. And because the gut is leaky, there's translocation of a lot of bacteria. Bacteria in the gut are translocated. And we know this because if we measure LPS, lipopolysaccharide, which is a product of a translocated bacteria, we see very high level of LPL in the gut. So these cells that are activated, that are proliferating, are able to engage this microbial translocated, this antigen that are coming from the blood, and therefore they are persistently activated. They are not like the normal T cells that you see in healthy individuals. So they are activated, and remember, activated cells produce cytokines. So we decided to explore this a little better, looking at the animal model of immune reconstitution and also looking at human. And so we take the TCR beta knockout mouse, which is a model of immunodeficiency. Excuse me. So these cells are immunodeficient, and so what we did, we did adoptive transfer of CD3, which includes CD4 and CD8. And then we looked at what happens to inflammation. So this is wild type here, and this is reconstituted. And when we look at levels of expression of TNF-alpha. And so you can see that with immune reconstitution, cells that are proliferating, they are actively proliferating, they are producing cytokines. And we see the production of of a TNF-alpha, both in the bone marrow, the spleen, also expression in CD4 as well as in CD8. We took this to human experiment where we look at HIV-infected individuals who were starting antiretroviral therapy. And then we look at changes in the level of TNF-alpha. Look at the first week, second week after treatment, 12 weeks after treatment, 6 months after treatment. You can see an increase in the level of TNF-alpha. But the story here is that not everybody. So remember, some people have elevation in inflammation, but not everybody. So if you go back again to the SMART study, that people, if you measure the level of inflammation before you start ART or during ART, some people have high levels, some people have low levels. And those that have high levels, we progress to develop cardiovascular disease. And so one of the things we see here is that when we start treatment, we reconstitute immunity in these individuals. You see that about half of them have increased inflammation. The other half have nothing. So what is really driving this inflammation? So one thought we had was that perhaps the destruction to the gut, so the amount of antigens, translocations from the gut to the systemic circulation may be driving this inflammation that drives some of the cardiovascular disease that we see. And so what we're beginning to do, these are all things that new concept that we're beginning to explore. If we change, we take our animal model of immune reconstitution, we reconstitute them. But in one group, we change the bowel, the environment of the gut. In the other group, the gut is intact. And then we look at the expression of inflammation. This time we were looking at Th17 cells, which produce a number of inflammatory cells. So these are still a preliminary result. But what we see is that when we change the milieu of the gut, you see that the level of inflammation is significantly different compared to those where the gut is intact. So kind of really thinking through this, our model is that in disease reversal, in the process of immune reconstitution, when you start people on antiretroviral therapy, they reconstitute their T cells. The T cells are proliferating and the proliferating cells are activated. And two, because they are increasing in number, just sheer increase in number, they are also able to engage with many of the antigen-presenting cells. And depending on the level of antigen that is available through destruction, translocation of gut bacteria to the systemic circulation, you see even more inflammation. And these inflammatory cells produce TNF-alpha, rank ligand, IL-6, and a number of inflammation that drives the process of end-organ damage in this population. So the last concept I just wanted to discuss with you in terms of inflammation, drivers of inflammation and cardiovascular disease in this population, is this issue that has to do with the abundance, the preponderance of cardiovascular disease in women living with HIV. So one thought we have was that HIV is a systemic infection. It affects the gonad. We know that. From the early stages of HIV, we know women that are living with HIV have compromised or diminished ovarian reserve. So the clinical evidence is that they have issue with fertility. 2, they have prolonged period of amenorrhea. And then 3, many of them actually achieve menopause earlier than about 2 to 3 years earlier than the general population. So remember that estrogen is an anti-inflammatory sex hormone. So high level of estrogen is protective, low level leads to inflammation that we see with postmenopausal diseases, where you have increased cardiovascular disease, increased bone disease in postmenopausal women. So the question we had is that to what extent does HIV affect the ovarian reserve in women living with HIV? And to what extent does that impact inflammation, the higher level of inflammation we see in this population? So data from the WIHS women, the women interagency cohort study, this cohort that we're involved in, clearly shows that if you just measure levels of estrogen, E2, you see significantly reduced level in women. And the second thought we also have, and this is a thought we're beginning to develop, is that women, because of chronic inflammation, the ability of women to use even the low level of estrogen that is available may be compromised, so that the expression of the estrogen receptor may be decreased because of chronic inflammation associated with HIV. So we're looking at the expression of estrogen receptor, both alpha and beta receptor in HIV-infected individuals, kind of similar to type 2 diabetes, where you have both absolute decrease in insulin, the ability of the cells to the pancreatic cells to produce insulin, but also you have reduced sensitivity of the tissues to utilize the insulin. So the question we have is that, do women living with HIV, first of all, have reduced level of estrogen production? That is, we know that for true. And the second thing is that they have decreased tissue expression of both the alpha and the beta estrogen receptor. So our preliminary result shows that there's a slight difference in estrogen receptor expression, especially the, I think it's the E2 receptor expression in HIV-infected individuals. So these are still very, very preliminary results that we are expecting. So the way we kind of put all of this together in the Emory score, which stands for Specialized Center of Research of Excellence, Specialized Center of Research Excellence on Sex Differences, is that a lot of these factors, the viral reservoir in the gut, the impact of disease reversal due to defective CD4 cell production, and maybe the impact of gonadal reserve connive to drive inflammation that leads to end organ damage, including cardiovascular disease, musculoskeletal disease, and also CNS damage. So that work is in progress, and hopefully in a few years, we'll have some result to report. The other concept I just wanted to share with you as I round up is the screening. So remember, I had said earlier on that a lot of the traditional risk, the calculator, the Framingham risk calculator and the American cardiovascular risk calculator are not very sensitive in the HIV setting. So we know that HIV-driven cardiovascular disease is an inflammatory process. And that inflammatory process acts to a very large extent through damage to the microvascular circulation. And is it possible? So we are now with my Dr. Lauren Collins, who was recently my fellow, became a faculty a few months ago in July, and now a KO2 scholar, is working in collaboration with our colleague in the Emory Eye Center to actually see if we can take a look at the vessels, the small vessels of the eyes. So there's this new technology called the optical coherence tomography angiography, where you can actually take very, very high definition images of the eye without contrast and be able to look at the integrity of the microvasculature of the eyes. So we're trying to see if we can detect early changes in the microvasculature, and if those early changes will predict or will help us predict the individuals that will go ahead to develop a cardiovascular disease. So the cohort, I just wanted to put a plug for our cohort, the MWSCS combined cohort study. It's a large cohort study. that involves almost 21 universities across the country with over 4,000 active participants. It's a comorbidity cohort. It includes both HIV positive and HIV negative in men and women that have been followed in the case of the men since 1985 and in the case of the women since 1993. And this is an aging population now that gives us an opportunity to really study a lot of these comorbidities in HIV-infected individuals. So this is a well-characterized cohort. There's ascertainment of a cardiovascular event that is adjudicated by experts. And we invite and welcome people who are interested to leverage this cohort. Lastly, we are also now part of what we call the IDEA, which is an international epidemiological database for AIDS. It's an international cohort that has over 2,000, over 2 million participants that can also be leveraged for study of cardiovascular and other comorbidities in HIV-infected individuals. So in conclusion, the burden is high, particularly in women, and some of the driving force include chronic inflammation and immune activation. And we think that the reservoir, immune reconstitution, and gonadal reserve may play a role. And we need a very sensitive tool for screening for cardiovascular disease in this population. I just want to acknowledge the leadership of my staff, Antonina Foster, Rachel Abraham, Shannon Walker, and my research team, as well as the research community that support a lot of the work we do here at Emory, and also the various funding agencies that are listed on this slide. Thank you very much for this opportunity.
Thank you so much, Dr. Ofotokun.
Yeah. So I'll stop sharing my slide. How do I do that now? I'll stop sharing it.
Share that for you.
Wonderful. And to all the attendees, you can send us your questions now through the Q&A. We do have one attendee with her hand raised. If you have a question, that's fine. If you don't, you might want to turn off your hand raised. I have a couple of questions. This was absolutely fascinating. Who knew so much about the immune system as cardiologists, but also how it affected the ovaries, estrogen, just all of it, fascinating. So one of the things I wanted to ask you about, Igho, is the socioeconomic groups and the demographic groups that are most affected by HIV. I know we have a lot here in Atlanta, but can you just tell us briefly, which groups are most impacted by HIV even today in 2020?
So that question, thank you very much, a great question. So if you look at the US, for example, before in the early part of the AIDS, it was mostly men who have sex with men. But now we see a significant increase in the proportion of women that are being affected by HIV, particularly in the South. So in the US, it's still a disease of men who have sex with men, particularly Black men, Black gay men. But if you look at the world as a whole, the burden of HIV, overwhelming proportionally, high up about it, over a half of all people living with HIV in the world are women. So in places like Africa, about 60% of all infected individuals, HIV-infected individuals, are women. So the women in general bears a greater burden of this epidemic than men, if you look at it globally.
I also had a question about the risk factors. We're constantly using the ASCVD pooled cohort risk calculator to determine a woman's risk when we're thinking about cholesterol medications, aspirin, everything. Is there something we should do, like maybe add 5% or 2.5%, or is there something we can do to better assess the risk in these women living with HIV?
Thank you very much. Great question again. I think what we know that the current risk calculator is not very effective. So to what extent should we accommodate the deficiency in HIV population? We don't have the answer. The only answer to that, we need to study what are some of the factors, variables, HIV specific variables that we need to include in the calculation, in the risk calculation, in order to improve the sensitivity of the risk calculators for people living with HIV. Or do we need a more sensitive tool like microvascular disease in order to predict cardiovascular disease in this population? So there's still a lot of work that needs to be done.
And one last question from me. So you said it's mostly single vessel disease and STEMI when the patient presents. So does that suggest that if they get proper treatment, stent, risk reduction medication, that this could be an isolated event? Or like other coronary atherosclerosis patients, do we need to follow them for a lifetime, being concerned that this is an ongoing accelerating process in them?
So remember, I am an infectious disease physician. So this is the
patients. What's your observation?
Yeah, this is a question I probably need to pose to my cardiology friend. How do we manage these patients? I think one of the things we definitely need to do is to be able to control the inflammation. So whatever we can do to reduce the driving force, the inflammation that really drives this, will be helpful. But once people develop disease, what I do is refer them back to you guys to manage. Yeah.
Wonderful. Thank you. And we are very focused on secondary prevention as well as primary prevention. All right. Well, thank you so much, Dr. Ofotokun, and we appreciate your time.